Hello and welcome to a video from Gerald. I am Dr. Gerald Richardson, and in this video we will review major depressive disorder. Before we get started, here's the list of objectives for this video. Throughout this video, we will present several questions that are designed to simulate real test questions that you may encounter. And at the end of the video, you will find a list of references used to support the information discussed here. Let's begin with what is major depressive disorder. The DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, has the following criteria: 5 or more of the following for 2 weeks, and it must include either A or B. That is depressed mood, anhedonia, which is the loss of pleasure, weight loss, slowing down of thought or physical movement, fatigue or loss of energy, feelings of worthlessness or guilt, poor concentration, and suicidality. Now note the DSM-5 is more detailed than this, so recommend reading the complete diagnostic criteria if you're interested. But for the sake of test questions, this should be what you need to know. Now, this is based on the DSM-5 criteria. If there is a new addition, say a DSM-6 or a revision to the DSM-5, I will update any changes to this and the rest of this video in the description. So I recommend reading the description for any updates. Similarly, if there's anything in here that needs to be corrected, that will also be in the description. The DSM also contains some information about prevalence. MDD is the most prevalent psychiatric disorder, and it's much more prevalent in females. So now let's jump into some practice. A 30-year-old female presents with low energy, fatigue, and poor concentration. She stated that she has barely left bed all week due to feeling very down. She also reports difficulty falling asleep and waking up earlier than she would like. She has decreased appetite and thinks she has lost some weight. She has no significant past psychiatric or medical history. The only medication she takes is an oral contraceptive pill. She does not use illicit substances, but has recently increased her alcohol intake from an occasional glass of wine at night to about 2 per night, some nights of the week. Physical examination and labs are unremarkable. What is the best next step in management? Here are the possible answer choices. Now, if this was recorded in front of a live audience, I would give you guys a moment to think about this and answer. But for this question and the rest of the questions in this video, just pause at the question if you want to take a moment to think about it before I give you the answer. So the answer to this question is D, prescribe escitalopram. In this clinical vignette, we see that this patient has many of the symptoms that we just reviewed for MDD: low energy, fatigue, poor concentration, difficulty falling asleep, feeling very down. And although we weren't given an exact time frame, we see that it has been going on for at least a week. So this patient likely has MDD. Now looking at the answer choices, the best option is to prescribe an antidepressant. Methylphenidate is a stimulant typically used for ADHD. Recommending alcohol cessation might be helpful. She has increased her alcohol intake, but it's unlikely to really target these symptoms of depression that she's experiencing. We will talk about different forms of psychotherapy later in this video, but supportive psychotherapy is typically used for patients who are in crises or lower functioning patients. This patient might likely benefit from a form of psychotherapy, but supportive psychotherapy probably isn't the best option. And considering an alternative contraceptive option is unlikely to help with her depression symptoms. So we mentioned escitalopram. Let's talk about the 5 major classes of antidepressants. These are selective serotonin reuptake inhibitors, SSRIs, serotonin and norepinephrine reuptake inhibitors, SNRIs, tricyclic antidepressants, monoamine oxidase inhibitors, and atypical antidepressants. Here's a list of examples of medications for each of these classes. Now, I plan on creating videos that will cover the different types of antidepressants and discuss more about psychopharmacology. So we won't dive too deep into that here, but since we are discussing major depressive disorder, it is appropriate to show what our options are for antidepressants. If you're interested in learning more about these in depth, be on the lookout for those videos. Now, out of these 5 classes of antidepressants, there is currently no specific go-to antidepressant for major depressive disorder. When determining which antidepressant to start, you should consider the patient's symptoms and the side effects of the antidepressant. In general, an SSRI or SNRI is often tried first due to a slightly better side effect profile compared to others, especially TCAs and MAOIs, which can have some nasty side effects. Now, there is still a lot of debate as to why antidepressants work. One of the theories is the biogenic amine theory. This states that the etiology of major depressive disorder is low levels of amine neurotransmitters, namely norepinephrine and serotonin, in the synaptic cleft. Here we're going to write out the pathways for how some of the neurotransmitters are synthesized. Now, this is a little lower yield, but I have seen test questions asking about this. So norepinephrine, which is one of the big neurotransmitters when talking about MDD, is derived from dopamine, which is derived from tyrosine. So I would definitely know that norepinephrine and dopamine come from the same basic amino acid, which is tyrosine. And I'm listing the enzymes for each of these steps. The main one I would know, if you have to know any, is the first one, which is tyrosine hydroxylase, which converts tyrosine to L-DOPA. This is the rate-limiting step for the synthesis of norepinephrine. The next pathway is for serotonin, and the main takeaway from this is that serotonin comes from the amino acid tryptophan. And notice how serotonin is metabolized by MAO. That is why MAOIs, monoamine oxidase inhibitors, can help with depression. They block the breakdown of serotonin, which in turn increases serotonin levels. And although we're not discussing sleep right now, I do want to add in a side note that melatonin is also derived from serotonin, and that is a question I have seen before as well. And finally, some of the high-yield neurotransmitter changes in depression are the following: decreased serotonin, decreased norepinephrine, and decreased dopamine. Let's move on to the next practice question. A 50-year-old male presents with low motivation and loss of interest. He explains, "I don't enjoy anything anymore. It's hard for me to leave the house, and I'd rather sit on the sofa all day. I don't even answer the phone for my friends. I'd rather be alone." The patient's medical history includes hypertension, hyperlipidemia, coronary artery disease. Family history is significant for his uncle and father both passing away from a heart attack. After a thorough psychiatric evaluation, the patient is diagnosed with MDD, and helping the patient better understand his diagnosis and prognosis, which of the following should be relayed to the patient? Again, pause the video if you want to think about this for a moment. The answer to this question is answer choice D. Depression that is not treated has been associated with increased morbidity and mortality from cardiovascular disease. There is a bidirectional link between depression and cardiovascular disease. Depression increases a patient's risk of cardiovascular disease, and cardiovascular disease increases a patient's risk of depression. Okay, next practice question. A 46-year-old male presents with insomnia for 1 month. He has been anxious about his work, which keeps him awake at night. He estimates that he sleeps about 4 to 5 hours each night. When he is at work, his concentration is poor from lack of sleep. He explains that he has made multiple minor errors at work, which his boss has noticed. Additionally, the patient has been increasingly irritable with his family at home, and on the weekends he would rather lay in bed all day instead of socializing with friends or doing activities with his wife and children. He explains that because of his poor sleep, he has not been experiencing any pleasure in these activities anymore. Although the patient feels guilty about this, he hasn't been able to find the motivation for several months to be more engaged with friends and family. The patient has no significant past medical or psychiatric history, physical exam and labs are normal. Which is the best next step in management? The best answer is answer choice E, prescribe sertraline. Although the patient's chief complaint is insomnia, there are multiple things pointing towards depression, such as decreased interest in activities, lack of pleasure, poor concentration, and guilt. Because this patient's insomnia is likely due to underlying MDD, it is better to treat the depression, that is, prescribe an SSRI like sertraline, rather than just treat the insomnia in isolation. If the insomnia does not improve with antidepressant therapy, then you can add sleep agents like trazodone or conduct sleep studies to better target the insomnia. The purpose of this practice question is to demonstrate how they can try to make it sound like a patient has a different diagnosis, especially if that's what the patient's chief complaint is. And it's your job to think a little bit more deeply about what is going on. Oftentimes, patients present with a chief complaint that is different than depression, either because they don't realize what they're suffering is depression, or because there's one component of the depression that is the most debilitating for them, or some patients don't want to admit that they think they might have depression. But as far as test questions go, they love to throw in questions like this to get you to fall for the trap of going down the path of insomnia. Just look at how many of these answer choices are related to treating sleep alone without targeting the depression. Next practice question. 2 weeks ago, a 40-year-old male presented to clinic with low energy, poor ability to focus, and depressed mood. He was diagnosed with MDD and started on sertraline. Today he returns to clinic reporting that he still feels depressed but has more energy and is able to focus better at work. However, he is concerned about new symptoms he associates with the medication, including mild nausea and occasional restlessness. The patient denies illicit drug use but does consume about 1 drink per evening. What is the best next step in management of this patient? The correct answer is D, reevaluate the patient in 1 month. The main key to this question is the timing. The patient has been on an SSRI, sertraline, for 2 weeks. An adequate trial of an antidepressant is 4 to 6 weeks. So as long as the patient has no side effects or tolerable side effects like mild nausea, what you should do is continue the patient on the SSRI at a therapeutic dose for the entirety of an adequate trial, which is 4 to 6 weeks, before considering making any changes. Now here are 4 important possible outcomes to antidepressant therapy that you should consider. The first is patients who are responders with mild tolerable side effects. For these patients, it's best to just continue the antidepressant. Next are patients who are responders but have intolerable side effects. These patients typically benefit from switching the antidepressant for another antidepressant in the same class. For example, a patient feeling 80% better on fluoxetine but has intolerable side effects may benefit from switching to citalopram. Citalopram and fluoxetine are in the same class. They're both SSRIs. The reason is because the patient is a responder to one of these medications, it is likely that they will respond to another med in the same class. But medications in the same class may produce different side effects. So a patient who's 80% better on fluoxetine with bad side effects might still feel significantly better when on citalopram, but they might not have those side effects. Next are patients who are partial responders and have tolerable side effects. In this case, the best option, especially for test questions, is to go with augmentation therapy. Here are the main augmentation options. You can add an antidepressant that's in a different class. For example, a patient who feels a little bit better on an SSRI and has tolerable side effects or no side effects, but they need a little bit extra help. A good idea might be to add bupropion, which is in a different class. Another option is to add a second-generation antipsychotic. A very commonly used one is aripiprazole. The next option is adding lithium. And then finally, especially for patients who have hypothyroidism, is to add thyroid hormone. And then the final possible outcome is patients who are non-responders, and that is after an adequate trial, then you want to consider switching to another class. Next practice question. A 36-year-old male diagnosed with MDD is started on sertraline. At his follow-up appointment 2 months later, he states, "I feel a little better. I went biking with my friend for the first time in months last week. However, I've noticed problems with sex. I'm able to get erections, but it takes me a very long time to ejaculate, or I might not do so at all. Because of this, I have been considering stopping the sertraline. What is the best next step in management?" The best answer is answer choice D, discontinue sertraline and initiate bupropion. The main sexual side effect of SSRIs and SNRIs is anorgasmia, or delayed ejaculation. It is not erectile dysfunction, which is a common trap answer. If you are asked anything about the sexual side effects of SSRIs or SNRIs, I can guarantee you that erectile dysfunction will be an answer choice. That is a trap answer. The sexual dysfunction is actually one of the major reasons for medication noncompliance. The patient above was considering stopping his antidepressant due to this side effect. Therefore, the best option for this intolerable side effect is to switch the antidepressant for another one. Now it looks like he might be a partial responder. He says he's feeling a little bit better. He went biking for the first time. And of these answer choices, we don't have the option to switch to another antidepressant in the same class. But even if we did, it might be better to switch it to a different class, specifically bupropion, because bupropion is one of the medications that is known to not cause sexual dysfunction in treating depression. And as a side note, this side effect of SSRIs or SNRIs of anorgasmia might actually be useful in helping patients with premature ejaculation. Now we're going to transition to discuss some of the major sleep changes in major depressive disorder. I have had several test questions related to this. So in general, some of the sleep changes are multiple awakenings throughout the night, initial and terminal insomnia, that is hard to fall asleep, and early morning awakenings, waking up much earlier than the patient desires. REM sleep is shifted earlier, that is decreased REM latency, the amount of time it takes to get to your first REM cycle. And REM is greater in duration. In stages 3 and 4, the deep sleep or delta is decreased. And another important biological change in major depressive disorder is cortisol levels. Those are increased. High cortisol due to hyperactivity of the hypothalamic pituitary adrenal axis. Cortisol is the stress hormone. High cortisol in states of high stress. This can be demonstrated by failure to suppress cortisol levels in the dexamethasone suppression test. I've seen that as a random test question before as well. Here's the next practice question. A patient with history of single episode of MDD is started on an SSRI. 4 months later, they feel great and are requesting to be off the medication. What should you do? The correct answer is continue the SSRI for 6 months at the same dose. This is called the continuation phase. The continuation phase is continuing an antidepressant treatment for 6 months after a patient reaches remission of their depression. This is different than the maintenance phase. Maintenance phase is continuing an antidepressant medication past the initial continuation phase treatment for 1 to 3 years. And this is typically done for patients with 2 or more episodes of depression, that is, a high risk of recurrence. So patients with a single episode of depression who achieve remission do not require the maintenance phase treatment. Patients with a history of highly recurrent MDD, that is 3 or more lifetime episodes, chronic episodes, 2 or more years of depression, strong family history, or severe episodes, including a suicide attempt, they should continue maintenance phase treatment indefinitely. And here are some of our definitions. I don't think you need to know the exact time frame, but partial remission of MDD is no symptoms for less than 2 months, and full remission of MDD is no symptoms for 2 months or longer. Now let's discuss for a moment electroconvulsive therapy. In general, ECT is indicated for MDD patients when there is the following. They are unresponsive to pharmacotherapy. They cannot tolerate pharmacotherapy. For example, they're pregnant. Without diving too deep into it, there are some conditions that when present in pregnancy, it's better to treat with ECT than to give medications which may have teratogenic effects. Or if rapid reduction of symptoms is needed. For example, immediate suicide risk, or the patient is refusing to eat or drink, or they're catatonic. A key point is ECT is safe in pregnancy, whereas some psychotropics can have negative consequences on the growing fetus. And as a side note, in addition to ECT, lithium and clozapine have efficacy in treating suicidality. I have seen test questions ask which of the following medications can be used to treat acute suicidality. Lithium and clozapine are your medication options, and ECT is a procedure that can help with suicidality. Next practice question. Lead-in paralysis is a feature most commonly seen in what type of MDD? MDD with melancholic features, MDD with atypical features, MDD with seasonal pattern. The answer is MDD with atypical features, and we'll talk about each of these next. So atypical depression is characterized by the following. The presence of mood reactivity, that is, they have the capacity to feel at least 50% better and even become transiently euthymic when exposed to positive events. For example, being invited on a date or given a compliment, the patient no longer feels depressed. Also, at least 2 of the following 4: increased eating, increased sleeping, lead-in paralysis, and interpersonal rejection sensitivity, which is a pathologic sensitivity to rejection or criticism. And lead-in paralysis, what that question was asking about, is referring to patients who feel as though they cannot move their limbs, that their limbs feel very heavy, as if they're full of lead. Next is MDD with melancholic features. This is more common in the elderly. Melancholic depression is the following: anhedonia, which is lack of pleasure, and or lack of mood reactivity. For example, grandparents don't cheer up when their grandchildren come to visit. That's the opposite of mood reactivity. At least 3 of the following: severe weight loss or loss of appetite, psychomotor agitation or retardation, early morning awakening, guilt that is excessive, worse mood in the morning, and or depression that is subjectively different from grief or loss. And lastly is MDD with seasonal pattern. This was formerly called seasonal affective disorder, which you might still see it referred to as. This is most common in the winter, and this form responds especially well to light therapy. So if you see a patient who seems to have MDD, but it kind of comes and goes with the seasons, and especially if it's more common in the winter, and one of the answer choices is light therapy, go with that. So these variants of MDD with atypical features, with melancholic features, or with seasonal pattern, are not as high yield as just MDD, but I would still be aware of these variants. And the last thing that we will discuss here are the high yield points of psychotherapy. Of course, this is not everything that there is to know about psychotherapy. There are several forms of psychotherapy. The 2 most common and most effective for MDD are cognitive behavioral therapy, CBT, or interpersonal psychotherapy, which deals with relationships. Here is a table that summarizes the high yield associations. Again, it's not all inclusive, but if you have a test question related to this, more than likely it's going to be matching these therapies with the indication. So interpersonal psychotherapy is great for depression. Psychodynamic psychotherapy is great for personality disorders or higher functioning patients. DBT, almost always, if you have a question about borderline personality disorder and DBT is an answer choice, go with that. Biofeedback is great for pain disorders or prominent physical symptoms. Motivational interviewing is for substance use disorders. Supportive psychotherapy, which we mentioned at the start of this video, is good for patients in crises or lower functioning patients. And family therapy is great for schizophrenia and psychotic disorders. And with that, this concludes the review on major depressive disorder from Gerald. Be sure to check out that website. I'm going to be adding more study guides, handouts, practice questions. It's an ongoing project, so be sure to check from time to time to see if there's anything new added. And lastly, if you have any feedback for me, good or bad, let me know and I will utilize it moving forward to make better content. Thank you so much for watching this video. I hope you learned something, and I will see you in the next one.